Well, hi everyone. My name's David Paling. I'm a neurologist from Sheffield. And I'm really excited today to be talking to Gavin. We both went to the virtual EAN meeting. And we've got some really great highlights that we'd like to show to you. Gavin, would you mind introducing yourself as well?
Yes, I'm Gavin Giovannoni. I'm a neurologist based in Whitechapel. I work at the Barts Health NHS Trust, and I'm linked to the university, Queen Mary University, London. And yes, I did spend some time on the EAN virtual conference platform. And you've got to be pretty dedicated because the weekend it ran, it was the most wonderful summer holiday, I almost feel about it. And so I've spent more time after the event going into it. So I've got a few highlights I'd like to discuss with you.
Well, there's nowhere more dedicated than you. So may I start off with a question to you, Gavin? We heard
Sure.
some, we saw some things about plasma NFL. So do you think this could be a marker for a treatment effect in people with progressive multiple sclerosis?
Yes and no. I mean, I think the presentation I'm particularly was impressed by was by Amit Baor looking at serum neurofilament levels from the ocrelizumab relapse and remitting and the oratoria trials. And I think we are entering a phase where neurofilament level testing, particularly in peripheral blood, is going to reach prime time, and it's going to get to our clinics because people may or may not be aware that a diagnostic test is coming out on one of the standard platforms, the Siemens platform, which most hospitals have got. So very soon you'll be able to order neurofilament levels. And based on the published data and all the studies, it looks like it's another inflammatory marker, and a very good inflammatory marker. It picks up, correlates very well relapses and GAD-enhancing lesions and T2 lesions on MRI, and it's quite predictive. But I also think it adds additional information in the sense that it may pick up microscopic disease that's not picked up on MRI, because there are quite a few patients that have raised levels with no evidence of MRI activity. And I think the good thing about the Amit Baor's presentation, he did show that there was a hierarchy. So the inflammatory relapsing patients had higher levels than the primary progressive patients. But the interesting thing is there was a treatment effect in both groups, both the relapse and remitting. There was a clear treatment benefit. In other words, ocrelizumab lowered neurofilament levels much more than interferon beta. And in the primary progressive, there was also a significant lowering of neurofilament levels relative to placebo. So I'm actually thinking we may have our the equivalent of a glucose or an HbA1c in this MS space. In other words, we'll be able to measure serially neurofilament levels and look at the area under the curve and hopefully reduce that area under the curve as much as possible. So I actually, wouldn't it be nice to have a home monitoring test? You put this onto a finger prick and you do it at home once a week, and you create your own trajectory of neurofilament levels and you target a specific area under the curve. So I think the fact that all this data is consistent. So we just saw ocrelizumab, but I can show you results around natalizumab, alemtuzumab, fingolimod, siponimod. So I think the evidence base is getting very, very large, and hopefully this assay is going to be reliable and hit clinical practice very soon. And then we'll be ordering, instead of MRIs, we'll be ordering neurofilament tests in peripheral blood, maybe every 3 or 6 months. I would imagine the more frequent we measure it, the better the data will be. And it's going to transform the way we manage MS, because who wouldn't want a low neurofilament level if you had MS? That's the question you've got to ask yourself. If you had MS, where would you want your neurofilament levels to be? I want them to be as low as possible. So I think it's going to become our treatment target. That's one of my highlights. You, David? Something practical, because most people watching this will be healthcare professionals. Did you see anything at the meeting that would change your practice tomorrow in clinic?
Yeah, I did. And I actually found the format of the meeting was quite helpful for this. You could pick the sessions that you felt would be particularly practical for you. And you could pause and think about the nuance and go back in time and really take the time to think about how it related to the people that you see in clinic every day. So I have a busy MS practice like you, and I see people with new diagnoses in clinic. And I feel fairly comfortable with those consultations. I'm able to give people the latest up-to-date guidance on how well disease-modifying therapies work and my experience. And they can talk about their priorities. And together we can make a really good joint decision about what we're going to do. And when that works well, it's really nice. We both walk away confident that we've made the best decision. And the patients, after having the devastation of having a diagnosis of MS, they can look forward to doing something positive to help themselves. And I get that warm glow inside that I've helped someone at a really difficult point in their life. And it's not always like that. And where it can be really hard is where it hasn't really gone so well, and you're seeing someone a year or two down the line and they've had a relapse or disability worsening on their treatment, or the scan shows lesions. And it's much more complex. The psychology is different. And you really want to give people some hard information about what they can expect. And that's harder to come by because most trials don't look specifically at people who haven't done well on their previous treatment. There were 2 trials presented which provided some clear figures that I can share with people in that situation next week. And the trials were called the Casting and the Cord study. And these trials were different to most trials in MS, as you're only able to get into the trial if you'd previously been on a disease-modifying therapy and it not completely work, having a relapse, a gut-enhancing lesion, or more than 2 T2 new lesions. And in both studies, most people are on treatments that we commonly use first line in the UK, so a combination of beta interferon, glutaric acetate, fingolimod, dimethylfumarate, and teriflunomide. And then all patients started onto ocrelizumab, and they were followed by an NMRI scan and clinical assessment over 2 years. And a few take-home figures for me that I can discuss with patients who are considering making that same change. 91% of people finished the study. And I think this is quite important. People vote with their feet. And to complete a study, particularly an open label study, you have to be pretty sure that you're doing well on your treatment, it's not burdensome and cause side effects, and you can't really think of a treatment that you prefer better. And more than 9 out of 10 people felt that way even after 2 years. The casting study was particularly interesting because they did a further scan at 8 weeks, because they knew from earlier studies that it took about 6 to 8 weeks for the medicine to work completely. That might seem a little bit like cheating, but I think that's quite a pragmatic decision. When you want to know how well a medication works, you don't want to know how well it works over 2 months. You want to know how well it works over years and years and years. And when they did that, they found that 75% of people were NEDA3 at 2 years. And that's quite impressive because these are people with highly active MS. And that means no relapses, no disability progression, and no new lesions. And 90% of people had no lesions at 2 years when they looked at the scan at 8 weeks. I think having these really clear figures will help when people are thinking of making the same decision next week. And I'll be happy to share that with people when I see them in clinic. And I think it will really help people know what they can expect and give them a little bit more confidence in their decision. So I think that's really important in day-to-day clinical practice. But something else that came up that I think is relevant, and I think we often struggle to assess very well in clinical practice, is progression without relapse activity. So these people who get gradually worse without clear relapses. So you looked at some studies about this, Gavin, and do you think that could be relevant even in relapsing remitting multiple sclerosis trials?
Well, yes, I think, you don't just go from relapsing remitting to secondary progressive. It's not like a light switch. I personally think they're part of the same disease. What you're seeing is people running out of reserve in a pathway, and then what happens is when they start getting worse, it looks like they've got progressive disease, but they've been probably doing that with reserve and compensating for the damage for years. But because of that concept, in every single relapsing remitting trial, there must be a population of patients that have got secondary progressive disease. And so when you actually can go in and analyze a relapsing remitting trial, you can actually pull out what I would call people with apparent secondary progressive disease. And this is what progression independent relapse activity is trying to find that population of patients in a relapsing trial that are getting worse without having relapses or outside of the relapse window and not linked to the window. So this is why one of my highlights was the ofatumumab versus the teriflunomab phase 3 program, where they actually went in and did a peer analysis, and they found that, not surprisingly, ofatumumab is effective in reducing progression independent of relapse activity. Now, why that's important is because ofatumumab is such an effective suppressor of relapses that there was very little progression that was driven by relapses. Most of the progression in the trial was occurring outside of relapse activity, and it still reduced that relative to teriflunomide. So I was a little bit skeptical about ofatumumab's ability to penetrate the CNS potentially, or deep tissues, and address this what I would call the secondary progressive pathology, the smoldering MS. But it looks like it has an impact relative to teriflunomide, and that's a really good. That's a really important observation going forward. So when ofatumumab does arrive, we probably, as an MS community, can say that this drug not only works on relapse activity, but it's also slowing down the process that are driving the smoldering MS, the worsening that is occurring independent of relapse activity. And I think so going forward, this is probably going to be one of the metrics we use to separate out therapies that work on progressive MS, non-relapsing MS, versus those that don't. So I think a lot of the old data sets are going to be reanalyzed from the phase 3 programs to look for this particular outcome measure. How good is disease-modifying therapy X in slowing down or impacting on progression independent of relapse activity? And maybe the regulators will come to realize that this is probably a very important metric, because it's asking the question, is this disease-modifying therapy targeting processes, that are not driven by focal inflammatory activity? And so that was a highlight for me. I'm probably focusing on the esoterics, because trying to communicate that to a patient in clinic will be quite difficult. Maybe they'll understand it. Anything surprise you in the meeting, David?
Yeah, this one's quite technical, but bear with me, Gavin, as I think it could be really important. And as you and I know, most people do pretty well with ocrelizumab, but people, particularly with progressive MS, do get more disabled over time. And it's hard to know if this is inevitable. This is just the treatment effect of ocrelizumab, and it's doing everything it can, or whether if we just increase the dose a little bit, like we would do for an anti-epilepsy medicine or azathioprine in another neuroinflammatory disorder, it could work better. And a year ago, I saw this presentation at the EAN presented by Professor Hauser from San Francisco, and they looked at all the people on the phase 3 trials of ocrelizumab. And when they put the data together, they found that the people with the highest level of ocrelizumab in the blood and the most profound depletion of B cells did an awful lot better from their ocrelizumab treatment in terms of disease progression. In fact, those people in the highest quartile of ocrelizumab in the blood, they had less than half the chance of disease progression compared to the lowest. But that study didn't really look at why the differences in ocrelizumab level existed. And there was a very neat study. It was quite simple, but it was quite clever. So Dr. Signorelli and his colleagues in Naples just looked at all their patients on ocrelizumab, and they split the sample into these slow repopulators. So these are people that they defined as having less than 2% of the B cell count at 6 months, and faster repopulators, and they populated to greater than 2%. And they looked at lots of things that could separate the two groups. But the only thing that they found is that the faster repopulator group had a significantly higher BMI on average, and it was 25.8 versus 23.6. What really surprised me was the RSC curve analysis. So that showed the point at which you were more likely to be a faster repopulator, which is bad, was at a BMI of 25.1. And I had to remind myself of this, but actually the normal BMI is 20 to 25, and the mean BMI of women aged 25 to 30 in the UK is 26.9. So if you put that together with the previous study, it shows that perhaps for people with a higher BMI, we may just not be giving them enough ocrelizumab. And I know that there's going to be a study to see if we should adjust ocrelizumab according to people's weight. So I actually took quite a lot of hope from this, that actually some of those people who aren't doing quite as well as we'd like on ocrelizumab, it may be that we're just not giving them enough. And perhaps if that study shows that it's safe to do so, we can start giving people a little bit more and hopefully stabilizing their disease a little bit better. What are your thoughts, Gavin? Do you think this could be something we do?
Yeah, I do, and I think that one of the targets for anti-CD20 therapies or B-cell therapies will have to be the intrathecal compartment, those B-cell follicles in the central nervous system that drive plasma cell formation, and those oligoclonal bands, which I think are pathogenic. And there is some pathology studies that suggest they're pathogenic. They either activate complement, they may be responsible for that subpial lesion or that slowly expanding lesion. So we're going to have to, at some stage, get drugs in to target these B cells. And it may just be those people with low BMIs are getting more CNS penetration. Or it could be a deep tissue effect, depleting the population of B cells in the secondary degree. We haven't optimized the dose of anti-CD20 therapy. We may need higher doses. Now, that's going to come with a cost possibly of safety, but it may not mean you need the dose forever. You may just need it for like a window, the first 2 years, then you could probably adjust dosing after that. So there's lots still to be discovered, and it's fantastic that, and I actually think this is not only relevant to anti-CD20 therapies, it looks like the same issues hold for natalizumab. We may have to optimize dosing depending on body size in terms of receptor saturation and reducing PML risk, which we are studying at the moment in a phase 4 trial. So there's lots still to be done in terms of optimizing the dose of MS therapies, which is good news in terms of trying to have little marginal improvements in outcome for our patients.
Great. Keeping with progressive MS, we got some information about siponimod from this conference. And siponimod, I've always been a little bit skeptical that it's different significantly from fingolimod, but there's some data here that I think should change my mind. So could you take me through that, Gavin, please?
Yeah, so most people just have a knee-jerk response. Oh, siponimod's a me too. It's just a fingolimod-like agent. What's the advantage? But there is quite clear differences between fingolimod and siponimod. In terms of the biology, fingolimod binds. As you know, there are 5 S1P receptors. Fingolimod binds to all of them except receptor 4. And siponimod binds the S1P and the 1 and 5 receptor. The 5 receptor is very important. I'll come back to that. The other thing that's different is fingolimod is actually inactive. It's a prodrug and it has to be phosphorylated, whereas siponimod is an active drug from the word go. So you can actually imagine it having a wider impact. And then the biggest surprise, because I actually think primary progressive and second progressive are the same disease. It's just a matter of phenotypes. Fingolimod was strikingly negative in primary progressive disease with no impact on brain volume loss. So there wasn't having any impact on the central nervous system. And now we're having siponimod having a clear impact on the central nervous system. Not only did it slow down whole brain volume loss, there were presentations given by Patrick Vermeesh showing you that its impact on the gray matter volume, which is probably more easier to measure, cortical, and then the deep gray matter structures, thalamus, etc., was quite profound. And so there's clearly a disconnect between fingolimod and siponimod in terms of its CNS effects, and that may be driven by this S1P5 receptor, because this is expressed on glial cells, astrocytes, oligodendrocytes, and may be responsible for and it's probably not blocking that receptor. Siponimod looks like it's actually an agonist at that receptor, so it may be changing glial biology, which is having an impact on the end organ. And so is this clinically meaningful? Yes, it is, because although it wasn't a primary or secondary outcome measure, there was a strong impact of siponimod in slowing down cognitive loss in people with secondary progressive disease. So not only do we have a MRI pathological signature, we've got some pharmacology by separating these. There's a disconnect between PPMS and secondary progressive MS between their modes of action. And then we've got a clinical outcome, which is cognition. So I'm actually quite excited that these studies are clearly putting daylight between siponimod and fingolimod, and I actually do think they're different agents. We just can't assume that siponimod is a me too and replacing fingolimod. So that was also an important highlight for me, that the data is emerging that siponimod is a different drug to fingolimod.
That's great. You've changed my mind quite extensively.
Well, I mean, I should say, yeah. I was also quite disappointed because you probably heard NICE have just rejected Saponimod, saying that we should be comparing it to best supportive care, which is interesting because people with secondary progressive disease shouldn't be on any other DMT, which is a little bit atypical in the sense most of us don't stop our patients when they become secondary progressive immediately. We see what happens over time. But anyway, going back to the nuts and bolts of the conference, because the COVID-19 has forced us to go virtual, what was your opinion about the EAN being virtual? Was there anything that you came across that was better than attending a real face-to-face meeting?
Well, you're right, Gavin. It's very tricky to stay glued to your laptop when you have one of the nicest weekends in the UK and you're stuck in lockdown. But there were some things that I actually thought were better about a virtual conference. Normally when you go to a conference, it can sometimes be pretty cognitively overwhelming. Every 10 minutes you're being presented with someone's life work. And if you miss something on a slide or if someone next to you coughs and you miss it, there's no way you can ever go back and you might miss a really important insight. And in a virtual meeting, you can just stop, pause and really examine something. And there's two instances where that came up. The first was in a study of cladribine. So Dr. Magyari from Copenhagen, you were a co-author in this study, looked at relapse-free status in people in year 2 in people on cladribine. And she and you had done a really good and thorough analysis of the Clarity studies, the phase 3 studies. And it showed that cladribine was a really good MS treatment, and only about 13% or 1 in 7 people had a relapse in the first year of treatment. And if you're relapse-free in the first year, the news got better still. Your odds look really good. And only 92% of people had a relapse in year 12, so less than 1 in 12 people. So if you're seeing that person at year 1 and they've done well, you can be really reassuring. If you did have a relapse in the first year, then you were still more likely than not to be relapse-free in the second year of treatment, with 70% of people being relapse-free. And I initially thought that was pretty good, and I know the authors felt the same. And then I took some time, went back and thought, well, that still does mean you've got a 30% chance of a relapse. And I don't really like those odds for my patients. And I definitely discussed that with my patient about thinking about their treatment if they did have a relapse in the first year. And it's really good to have a nice clear number that you can discuss with people when you're thinking about what to do. And I wonder if some of that nuance might have got lost in translation if I'd been at a normal conference and the next slide would be on. The next was a study of autologous hematopoietic stem cell transplantation in people with aggressive MS. And this was from a doctor called Dr. Boffa in Genoa in Italy. And he looked at all the people who'd had stem cell transplantation in Italy from 1997 to 2009. And they did about 100 procedures during that time. When you go through something like hematopoietic stem cell transplantation, you want to know that it's going to work, not for 2 years, but hopefully for the rest of your life. And this study helps to an extent in that he was able to follow up people for 10 years. And the outcomes were pretty good. After about 10 years, despite not being on a disease-modifying therapy, 2/3 of people didn't have a relapse and half had no further MRI disease activity, which is pretty good, I felt, over 10 years. But actually what he didn't specifically mention, and the only way I found this was I screenshotted the slide and sort of zoomed in, is that they did compare 2 protocols. They compared the non-myeloablative protocol, and that's the one we use in Sheffield and is used in London. It's a much milder protocol. It's much more modern. And they also compared it to an older protocol, a myeloablative protocol called BEAM-ATG. And this is much more aggressive, and it is associated with much more treatment-related mortality and morbidity, and has largely been phased out. But the aggressive one is much more effective. So about 90% of people who went through this protocol were relapse-free at 10 years. There's lots of other things that might have been in play, but I do think, just being able to stop and pause really gave me some interesting information. And it would be interesting if people look at this protocol to see if in modern MS treatment it still has a place. So that was something that would have passed me by if I couldn't stop and pause. Gavin, every time I go to conferences, I hear really exciting things about neurofilaments, and I leave the conference entirely excited. And then I go back to clinic in Sheffield, and I can't think about how to use them in clinical practice. I've got no idea what to do. And you feel that there's something here in the conference that might help me on Monday morning when I'm sat in front of my patients. What can you help me with?
So this is work from our own audit and our incentive, just because we've been doing CSF neurofilament levels now for about for 4 or 5 years, and they've been arriving on our desks as part of our workup for patients as a service development. And the question we asked ourselves very, very simply is, knowing a neurofilament level, does it actually change decision making? In other words, or can you just ignore it? And we began conceptually to treat a raised cerebrospinal fluid neurofilament level as an inflammatory marker. It's like the equivalent of a GAD-enhancing lesion or a relapse, and it's become particularly helpful in people that are past the relapsing, more advanced disease, and you ask yourself the question: is this person active or inactive? And we had to make a decision around patients that have been referred to our center for off-label cladribine, compassionate use cladribine, and we actually made a decision that we wouldn't give cladribine to people that didn't have any evidence of inflammation, ongoing inflammation, and for that it was either clinical MRI and CSF neurofilament levels. So we were actually quite surprised that in about 15% of patients, just having an elevated CSF neurofilament level changed our decision making. In other words, made us stop or switch or start a therapy. And so I think this is actually like a bit of behavioral psychology in the sense that, yes, you go to meetings, you hear about neurofilament levels, and it's a theoretical concept. How's it going to impact my practice? I can tell you now, if neurofilament levels start landing on your desk because you've ordered them, they will change your behavior quite quickly because you won't be able to ignore them. You know about the biology of neurofilament levels. You know what they mean. They are poor prognostic factor. They predict brain volume loss. They predict disease progression. They predict cognitive impairment. They're associated with relapses and MRI activity, and they mean inflammation. So when you get that there, you can't ignore it. And it's quite good to see that the fact that we've been ordering these and have set this up as a service, it's actually affecting our clinical decision-making and our behavior. And the good news is that we're not the only center now. I think there are 4 other MS centers that send us CSF samples in all the time. And it's affecting decision-making because one of the consultants from one of the centers is phoning up our lab, harassing us for the results earlier. So it's also affecting that center's decision-making. So this is why I come away from the meeting, because so much neurofilament data was presented, knowing that it's going to have a massive impact on how we manage MS, having neurofilament levels. This is CSF, but it's going to move into the blood as well.
Well, that's perfect, and what a great thing to do to really show you centres experience and really help us out in working how we integrate that into clinical practice. Gavin, I got one last question. I knew you were a Fly guy, but I didn't know you were a Slim Shady fan. You asked us, would the real MS please stand up? What does that mean? What's that all about?
Yeah, so I mean, it's an insight I've had been developing. It's a concept that's been developing in my head for a long time now, probably 20 years, but it's become more and more profound. So there's 2 theories around MS, that MS is driven by focal inflammatory activity. Relapses, MRI activity is MS, and that's what causes, and everything that's downstream of that. But I'm beginning to think it's not. I'm beginning to think that the relapses and MRI activity is in response to what's causing MS. And one of the reasons for that's firming it up is the dissociation. So some of the data was presented of the ofatumumab versus teriflunomide data. And it's quite clear that ofatumumab, which is an anti-CD20, is pretty effective at switching off focal inflammatory activity. People are virtually relapse-free and MRI activity-free. So this is probably one of our most effective anti-inflammatory therapies. But its impact on disability progression was nowhere near as good as its impact on MRI activity, for example. And it had very little impact on brain volume loss relative to teriflunomide. And so I think what's the real MS is, it's that progressive brain volume loss and that disability progression that goes with it. And whether or not you have inflammatory activity may or may not modify the phenotype, but it's not what's causing the disease. So there's a ceiling floor effect in relation to organ brain loss. And what we really should be focusing on is therapies that can actually normalize or stop that brain volume loss. PIRA, progression independent relapse activity, that is the real MS. And so do we have treatments that slow that down? Yes, we have some therapies that seem to slow it down slightly, but I haven't seen any therapy that stops PIRA, stops the progressive brain volume loss once those processes are kicked into place. So I think this actually shifts our focus away from just targeting anti-inflammatory mechanisms and targeting the end organ. How do we develop therapies that can target those processes that's driving the progressive or inevitable neuroaxonal loss that underlies the progressive component of MS. So that's the real MS.
What would those treatments look like? What should we be thinking about?
So yes, I think we still need anti-inflammatory therapies, because I would be too nervous not to have an anti-inflammatory. But when you start to understanding what happens inside the brains of people who are needed to, no relapses, no MRI activity, there's lots of stuff going on in there. There's an energetic failure, there's demyelination, there is reactive oxygen species, there's mitochondrial dysfunction, there's premature aging mechanisms that are driving that. Some people say there may be a viral infection. There's data that potentially HERVs, human endogenous retroviruses, get activated, and some of their envelope proteins may be neurotoxic. So there's lots of therapeutic targets. I've already mentioned to you earlier that the intrathecal B and plasma cell response, those antibodies that are produced, may be binding targets and activating complement, or just by FC receptor stimulation of microglia, they create that so-called hot microglial environment. So, do we have therapies that can block FC receptor signaling in hot microglia? One of the targets that was also presented, we didn't discuss it, is a new class of therapy called the BTK inhibitor, protein tyrosine kinase inhibitor. So that's actually the kinase that sits behind the immunoglobulin receptor, and there's very good data showing you that it is effective in MS in terms of switching off inflammatory activity. But that kinase also sits inside the microglia and macrophage and is activated by the FC receptor. So we're going to get a class of therapy that actually not only inhibits or suppresses B cell activity, but it's going to target these hot microglia. And so we're entering a phase now where we're going to get new therapies targeting these processes that we think are driving the progressive component of MS, and the therapeutic target is going to be within the central nervous system. So this is kind of like I think this meeting represents a shift in that direction. Everybody's talking about these processes and how we should be targeting them. So that was one of the highlights for me.
Great. Well, that's hugely exciting stuff. And thanks so much for talking to me, Gavin. I've really enjoyed our talk, and I hope that's something for everyone to take away from the meeting. And I'm glad they did it. I'm glad that we were able to attend the meeting, and I think we've got some really good, exciting highlights of what we can expect in the future.
Take care.
Thanks very much. Bye.